Hello everybody, this is Dr. Mehtab, first year resident in Community Medicine Department. Today we will discuss about various methods of family planning, their advantages and shortcomings. So first of all, the definition of family planning. As per WHO, it is defined as a way of thinking and living that is adopted voluntarily upon the basis of knowledge, attitudes, and responsible decisions by individuals and couples in order to promote health and welfare of the family group and thus contribute effectively to the social development of a country. What are the objectives of family planning? To avoid unwanted births, to bring about wanted births, to regulate the interval between pregnancies, to control the time at which birth occurs in relation to the ages of parent, to determine the number of children in the family. These are the objectives of family planning. What do you mean by eligible couple? An eligible couple refers to a currently married couple wherein the age of the wife is in the age group of 15 to 44 years. That is called childbearing age. 150 to 180 such couples per thousand population are present in India. Then target couple. Eligible couples who have 2 to 3 living children form a target couple. These formed a priority group among the eligible couples. Now, even couples with just one or newly married couples are also considered a priority for family planning services. Classification of contraceptive methods. Spacing methods and terminal methods. Spacing methods are again classified into barrier methods, intrauterine devices, hormonal methods, post-conceptional methods, miscellaneous methods. Terminal methods are classified into male sterilization and female sterilization. In this video, we will discuss about the barrier methods and intrauterine devices. Now, barrier methods. Aim of barrier methods is to prevent the live sperm from meeting the ovum. Main advantage is absence of side effects associated with the pill and IUD. Then they are classified into physical methods and chemical methods. Physical methods contain condom, diaphragm, and vaginal sponge. Chemical methods contain foams, creams, and jellies, suppositories, soluble films. Then physical methods, condom, male condom and female condom. We can see both the images in this picture. So male condom is called Nirod. Condom prevents the semen from being deposited in the vagina. Effectiveness of the condom may be increased by using it in conjunction with a spermicidal jelly inserted into the vagina before intercourse. So these can be highly effective methods of contraception if they are used correctly at every coitus. Let us see the female condoms are like their pouch made of polyurethane which lines the vagina. It has two rings, internal ring and external ring. Internal ring, the close end of the pouch covers the cervix and external ring remain outside the vagina. It is an effective barrier to STD infection. Let us see the advantages. These condoms are easily available, safe and inexpensive, easy to use. It has no adverse effects, light, compact and disposable. Provides protection not only against pregnancy but also against sexually transmitted diseases. Then disadvantages of the condoms. Breakage and slippage decreases effectiveness, requires consistent and diligent use. Some men complain condom dull sensations. Typical use has a failure rate of approximately 14%. Some of the patients may report latex allergy. Then diaphragm, also known as Dutch cap. It is held in position partly by the spring tension and partly by the vaginal muscle tone. Spermicidal jelly always used along with it. Failure rate is 6 to 12 per 100 women years. The diaphragm is inserted before sexual intercourse and must remain in the place for not less than 6 hours after sexual intercourse. Next. Advantages are absence of risk and medical contraindications. Disadvantages, it can take time to learn How to use it? It doesn't protect against STDs. After delivery, it can be used only after the involution of uterus is completed. If left in vagina for long time, it can lead to toxic shock syndrome. Next, vaginal sponge. It is a polyurethane foam sponge 5 into 2.5 centimeter. In USA, it is marketed under the trade name Today for the sole purpose of preventing conception. Then it is saturated with a non-oxynol 9. Failure rate is about, in paracetamol it is about 20 to 40 per 100 women years, and in early paracetamol it is about 9 to 20 per 100 women years. These are the various methods we have discussed. They are like chemical methods. They comprise 4 categories: foams, foam tablets, foam aerosols, creams, jellies and pastes squeezed from a tube, suppositories inserted manually, and soluble films, C film inserted manually. These contain a base into which a spermicide is incorporated. Commonly used modern spermicides are surface active agents which attach themselves to spermatozoa and inhibit oxygen uptake and kill sperms. So drawback of spermicides. They have high failure rate. They should be used almost immediately before and after intercourse and after each act. Must be introduced into those regions of vagina where sperms are likely to be deposited. They may cause burning or irritation at genital region, and it should be free from systemic toxicity. It should not have inflammatory or carcinogenic effect on vaginal skin or cervix. Then we will discuss about the intrauterine devices. Intrauterine devices. They cause foreign body reaction in the uterus, causing cellular and biochemical changes in the endometrium and the uterine fluids. This impairs the viability of gamete and reduces its chance of fertilization rather than implantation. They are basically of two types: non-medicated and medicated IUD. This image shows various types of IUDs, like we can see the Lippels loop, then copper devices, copper T200B, 380A, 220C, Nova T, and copper multi-load device 375 and levonorgestrel, which is also called Mirena IUD. Then, who is ideal IUD candidate? It is a ideal IUD candidate. It is defined by Planned Parenthood Federation of America as a woman who has born at least one child, has no history of pelvic disease, has normal menstrual periods, is willing to set the IUD tail, has access to follow-up and treatment of potential problems, is in a monogamous relationship. These are the ideal IUD candidates. So these IUDs are again divided into three generations: first, second, and third generations. First generation IUD consists of Lippels loop. Uh, First generation and second generation both are non-medicated IUDs, and third generation IUDs are medicated IUDs. So Lippels loop is, these are inert or non-medicated IUD double S-shaped device. We can see it in the image. These are made of polyethylene, contain small amount of barium sulfate to allow X-ray observation. The tail is made of fine nylon. This tail projects into the vagina after insertion. Based on the size, they are divided into A, B, C, D in increasing size order. Then second generation IUDs. Earlier device, newer device. Earlier device is copper 7 and copper T200. Newer devices, variants of the T device like copper T220C. We can see the first image shows copper T220C. And the second image shows copper T380A or AG. In National Family Planning Program, so copper T220C was used earlier. Now copper T380A or AG is included in the program. The Nova T multi-load devices like multi-load copper 250 and multi-load copper 375. The last image is of multi-load copper 375. Mechanism of action. Copper enhances the cellular response in the endometrium. It affects the enzymes in the uterus, alters biochemical composition of cervical mucus, affects sperm motility, capacitation, and survival. Benefits of copper devices. They have low expulsion rate, lower incidence of side effects like pain and bleeding, easier to fit even in nulliparous women, better tolerated by nulliparous women, increase contraceptive effectiveness, effective as postcoital contraceptives if inserted within 3 to 5 days of unprotected intercourse. Then third generation IUDs. These are medicated IUDs, so hormonal IUDs. Progestasert or progesterone containing IUD and levonorgestrel. It is also called as Mirena. Progestasert is a T-shaped device we can see in the image. It is filled with 38 milligrams of progesterone. Progesterone is released in the uterus at the rate of 65 micrograms daily. It has a direct local effect on uterine lining, cervical mucus, and on the sperms. Then levonorgestrel, also called as Mirena. It is included in the National Family Planning Program of India. So this Mirena releases 20 micrograms of levonorgestrel daily. Effective life is about 10 years, 10 to 12 years. Advantages are low pregnancy rate, 0.2 per 100 women, less number of ectopic pregnancies, lower menstrual blood loss. Mechanism of action of hormonal IUDs. These hormonal IUDs increase the viscosity of the cervical mucus, prevents the sperm from entering the cervix, renders endometrium unfavorable for implantation due to high levels of progesterone, relatively low levels of estrogen. Then change of IUDs. Lipids loop can be left in place for a longer time. Copper T388 should be replaced after 10 years. Copper T200 replaced after 4 years. Nova T replaced after 5 years. And Progestasert must be replaced after every year. Levonorgestrel replaced after 7 to 10 years. Effectiveness of IUDs. These are the most effective reversible contraceptive methods. Lowest pregnancy rate is shown by levonorgestrel IUD. Highest pregnancy rate is seen in Lippel's loop, copper T200. Lowest expulsion rate is seen with progestasert. Highest expulsion rate is seen with Lippis loop. The lowest removal rate is seen in progestasert and highest removal rate is seen in levonorgestrel or Mirena. Advantages of IUDs. The process is very simple, like no complex procedure are involved, no hospitalization. Insertion takes only few minutes. Once inserted, IUD stays in place as long as required. Contraceptive effect is reversible, virtually free of systemic metabolic effects associated with hormonal pills. And they have highest continuation rate. No need for continual motivation as like needed for pill or barrier methods. Only one single act of motivation is sufficient for these methods. Then contraindications. These are classified into absolute and relative contraindications. Absolute contraindications include suspected pregnancy, pelvic inflammatory disease, vaginal bleeding of undiagnosed etiology, cancer of cervix, uterus or adnexia, and other pelvic tumors. A previous ectopic pregnancy. Relative contraindications include anemia, menorrhagia, history of PID since last pregnancy, purulent cervical discharge, distortions of the uterine cavity due to congenital malformations, fibroids, and an unmotivated person. In case of nulliparous women, IUD is not a method of first choice. It is used only when they cannot use or accept alternative methods of contraception. Smaller and more pliable IUDs like copper T are better suited to nulliparous women. According to American College of Obstetricians and Gynecologists, they don't recommend IUDs to nulliparous women and women with multiple sex partners. Then timing of insertion. Best time is during menstruation or within first days of beginning of the menstrual period. Then immediate postpartum also we can do the insertion. It is done during first week after delivery. Risk factors in immediate postpartum insertion, it can lead to uterine perforation or it is associated with a high expulsion rate. Then post-perpural insertion. It is done 6 to 8 weeks after delivery. Then it can be done immediately after first trimester abortion. It is usually not recommended after second trimester abortion. So four timings are given in this, right? Like during menstruation or within 10 days of beginning of menstrual period, immediate postpartum insertion, post-perpural insertion, and after first trimester abortion. Follow-up, we have to do follow-up of the patients. What are the objectives? To provide the motivation and emotional support for the woman, to confirm the presence of IUD, to diagnose or treat any side effects or complications. They should be examined after first menstrual period, third menstrual period, and at 6 months or 1 year interval. And what are the instructions we have to give to the patient? She should regularly check the threads or tail to be sure IUD is in uterus. She must consult the doctor if she fails to locate the IUD. She should visit the clinic whenever she experiences the side effects like fever, pelvic pain, bleeding, and if she misses a period, she must consult the doctor. And adverse effects and complications of intrauterine devices. Bleeding is the most common complication. It accounts for about 10 to 20% of all IUD removals. So to prevent iron deficiency anemia, we have to give ferrous sulfate 200 mg 3 times daily to those women who have uncontrolled bleeding. Then IUD is to be replaced or removed when the bleeding is heavy or persistent or patient develops anemia despite iron supplementation. Then pain. It is the second most common complication, accounts for 15 to 40% of IUD removals. Pain may occur during insertion, menstruation, and it usually disappears by third month. The pain manifests as low backache, lower abdominal cramps, and pain down the thighs. Causes of pain is faulty insertion technique, disparity in size between the device and the uterine cavity, uterine perforation, and infection. And pelvic infection, PID. So pelvic inflammatory disease. It involves acute, subacute, and chronic conditions of the ovaries, tubes, uterus, connective tissue, and pelvic peritoneum. Organisms causing PID may be Gardnerella, anaerobic streptococci, bacteroids, coliform bacilli, and actinomyces. Patient presents with vaginal discharge, pelvic pain, tenderness, abnormal bleeding, chills, and fever. So risk factors to develop PID. She may be having multiple sexual partners, introduction of bacteria during IUD insertion, or ascending infection from genital tract into the uterus. So PID may cause permanent blockage of fallopian tube resulting in infertility. Treatment is broad spectrum antibiotics and removal of IUD. Then uterine perforation. The perforations occur frequently when insertions are performed between 48 hours and 6 hours postpartum. So post perpural insertion. So diagnosed by pelvic X-ray causes peritoneal. This uterine perforation causes peritoneal adhesions leading to intestinal obstruction. Those copper devices which migrated into the peritoneal cavity may lead to peritoneal adhesions leading to intestinal obstruction and perforation of intra-abdominal organs. Management is by removal of the IUD and the symptomatic management to the patient. So pregnancy. Sometimes, even though there is an IUD, the patient may become pregnant. So induced abortion is legal in this scenario. If the female opts for abortion, we can do. If the woman wishes to continue the pregnancy, then we have to check the threads. If the threads are visible, the device should be removed by pulling the tails. The threads are not visible, we have to check for the signs of intrauterine infection and sepsis. Then we have to manage it by the evacuation of the uterus and broad spectrum antibiotics, under the coverage of broad spectrum antibiotics. 50% of the pregnancies with IUD inside to undergo spontaneous abortion. Only 25% of the pregnancies will have successful outcome even if IUD is left in place. So we should counsel the patient about all these outcomes. Then ectopic pregnancy. Clinical features of ectopic pregnancy include lower abdominal pain, dark and scanty vaginal bleeding or amenorrhea. High risk groups include women with a previous history of pelvic inflammatory disease, previous history of tubular ectopic pregnancy, and this ectopic pregnancy rate per 1,000 women year. In normal women, it is about 3.4 to 4.5 per 1,000 women years. In progesterone users, it is the highest, like 6.8 per 1,000 women years. For levonorgestrel and copper T 380A users, it is only 0.2 per 1,000 women years. So it is considered to be less than the normal woman. Then expulsion. Expulsion rate varies between 12 to 20%. Occurs most commonly in young patients, nulliparous women, and in postpartum insertion. It is diagnosed by speculum examination. Then stem of the IOD will be seen protruding through the cervix. Fertility after removal. 70% of previous IUD users conceive within 1 year of stopping use of these IUDs. So previous episode of PID only may hamper the fertility. Cancer and teratogenesis, no evidence of cancer risk or congenital malformations with the use of intrauterine devices. Mortality is 1 death per 1 lakh woman years of use. So very negligent. Causes of death may be due to septic abortion and ectopic pregnancy. So in the next part, we will discuss about the hormonal contraceptive.